Good day, everybody. We're going to talk about preconception and antenatal care. And I have put it in two parts. So once you finish this part, you'll go to the next one. So what do we mean by preconception care? The CDC, which is the Centers for Disease Control and Prevention, defines the preconceptional care as a set of intervention that aim to identify and modify biomedical, behavioral, and social risks to a woman's health or pregnancy outcome through prevention and management. That's the definition put to it. So it is a series of interventions designed for biomedical behavior and social risks modification so that the outcome will be a good prevention and management of pregnancy on its own. Preconception usually starts before conception, as the term implies, about 3 to 6 months prior to planning of pregnancy. What are the goals of preconceptional care? First, to improve the knowledge, attitudes, and behavior of men and women related to preconceptional health. So both couples, the woman and her husband, to be aware about pregnancy, attitudes to take to it, behavioral changes that could occur, to assure that all women of childbearing age receive preconceptional care services. This will enable them to enter pregnancy in optimal health. That's to say, the information was given or were given to them prior to the pregnancy. So when they enter into the pregnancy, they aim for an optimal health. Also, to reduce the risks indicated by a previous adverse pregnancy outcome through interconceptional interventions to prevent or minimize recurrent adverse outcomes. So if she had a previous experience which is rather unacceptable to her or causing some sort of risk to her or her child to be, then that will be addressed and hopefully reduced during the preconceptional care. Also, to reduce the disparities in adverse pregnancy outcomes. So just to summarize, improving the knowledge, assuring that all women receive preconceptional care services, reduce the risks of any problems, and reduce the disparities that may occur. So preconceptional care, the outcomes of it are dependent on the interaction of various maternal, fetal, and environmental factors. Mother, the environment, the fetus itself. So how pregnancy will affect the maternal health, we should address that. Just to say, counseling it to the mother-to-be. How a high-risk condition might affect the fetus. The mother should be aware of that. Many conditions may be amenable to intervention during the preconceptional and interpregnancy periods. That's to say, some diseases could be controlled in between pregnancies or before this pregnancy. That's why we do the preconceptional counseling or care. Advice, improving the outcome. That is because all this to be in the preconceptional period, because by the time that the woman recognizes that she is pregnant, the embryo has already been formed. So if there is any problem or congenital anomaly that will affect the embryo, that will start earlier. Example we give, neural tube defect, we give folic acid for it. We give it before the conception. So when we are dealing with the advice of the preconceptional care, then we know whether there is a history of neural tube defect for which we can give folic acid. Yes, just an example. Other conditions are many which we can intervene before the pregnancy takes place. The pre-existing conditions which we can and we should intervene or at least make them quite safe for the pregnancy, that these conditions are existing before the pregnancy. Commonest, diabetes, hypertension, she had renal diseases, venous thromboembolic disease, epilepsy, HIV, connective tissue diseases such as SLE, and maternal myasthenia gravis. So these are some of the examples which we deal with in the preconceptional period, and we give attention to, and we try and manage them prior to the pregnancy. So we have to go into the medical history of the lady during this period. Important areas in her history and also first degree relatives, because there are certain diseases which are familial or inherited. So the first degree relatives, siblings or parents, we have to take the history of them from diabetes. She is likely to get gestational diabetes if one of the first degree relatives had a history of diabetes. Thromboembolic diseases, this increased risk of thrombophilia and thrombosis. Preeclampsia in the family, or she had it before in her history, increased the risk of preeclampsia. Serious psychiatric disorders, here we are worried about puerperal psychosis. If she had a problem, psychiatric problem, or the family had a psychiatric disorder, the first degree relative, then we are worried about the lady to have puerperal psychosis, for which we should be careful and watch for it. Also, look for history of congenital anomalies. Excuse me. As well as genetic disorders. So these are diseases pre-existing in the lady or in the first degree relative. We have to look for them. So family history of diabetes. Diabetes associated with risks to both mother and fetus. Many of these complications can be avoided if glucose control is optimized before conception. That's to say, a diabetic mother or mother-to-be should have her diabetes controlled before embarking on a new pregnancy. And for that, we encourage the preconceptional goal that the hemoglobin A1C to be optimal for the mother, to state that the hypoglycemia is well controlled for the last 8 weeks to 3 months. So in addition to assessing diabetic control during the preceding 6 weeks or 8 or 3 months, hemoglobin A1C measurement can also be used to compute risk for major anomalies. Abnormal hemoglobin A1C or high hemoglobin A1C, likelihood of congenital anomalies to occur in the baby. So both will be affected by uncontrolled diabetes, the mother as well as the fetus. And we have to look for that. We have also to look for the reproductive history of the lady. And here we look for infertility, abnormal pregnancy outcomes that may include miscarriage, ectopic pregnancy, hydatid deformed body, etc. Recurrent pregnancy losses, obstetrical complications such as preeclampsia, placental abruption, preterm delivery. So all these, the reproductive history of the mother-to-be who is coming for preconceptional counseling or care, we have to look into these issues in her history. And if there is prior stillbirth, infertility, abnormal pregnancy outcomes, recurrent pregnancy losses, obstetrical complications previously, history of stillborn priorly. So we look also at the maternal age. We have to be aware that there are certain problems which occurs at the ends of the reproductive life. That's to say, very early when she is in adolescent period, or very late when she is perimenopausal or over the age of 40. So then there are certain problems that should be considered. If we take the adolescent mother, likely to get anemia, preterm delivery, preeclampsia concerned with women aged 20 to 35 years, incidence of sexually transmitted diseases common in adolescent and even higher during pregnancy. And unfortunately, most of these adolescent girls, the pregnancy is unplanned, so they may not come for preconceptional care. She may come to you when she is already pregnant, and still you have to manage her accordingly. So these are the possible complications in an adolescent girl who got pregnant, and we have to cater for that. Maternal age, older women may come and seek and request preconceptional counseling. Why? Either because she has postponed pregnancy and now wishes to optimize her outcome. And an example here we give, professional women, they usually start on their profession, they work for some time to get their position in the profession, and then after that, she tries to plan for her maternal role or to want to be pregnant. So she may come a bit late. This is why she can come on her own before the pregnancy to ask advice for that. Or she had come to you because of infertility. So in either situation, the older women may seek the advice or the counseling before conception. We know after the age of 35, there is an increased risk of obstetrical complications, as well as perinatal morbidity and mortality. So a lady after 35, whether she had a pregnancy priorly or this is the first pregnancy, is likely to have obstetrical complications as well as complications to the baby or the fetus. The paternal age, although autosomal dominant mutations in older men has been shown, the incidence is still very low. That's to say the paternal age does not affect the outcome of the pregnancy. Till now, we know that the men are fertile till they die or they have a problem. Women, they reach a stage whereby the fertility stops at the perimenopausal period. In the menopause, there is no fertility. So older women, some mutation has been detected, yet that does not affect the outcome of the pregnancy. These are the problems in advanced maternal age. The risks are preeclampsia, gestational diabetes, incidental medical problems like hypertension, for example, aneuploidy, and miscarriages. So advanced maternal age likely to be associated with these problems, and we have to be careful in preconceptional counseling as well as the antenatal period. Certain situations to have pregnancy at young age, as in the presence of mild renal failure. So some pregnancies, some advice you may give to patients with mild renal failure, if possible, to embark on her pregnancy early at an earlier age. That doesn't say that renal disease or renal failure contraindicates, yet women with renal transplant could conceive are at higher risk that they could be managed during the pregnancy. So if you can reach them early on, that will be a good advice to start her pregnancy. For the fetus with advanced maternal age, they may be indicated preterm delivery. That's for maternal complications such as hypertension or diabetes, or spontaneous preterm birth that could occur or increase with the increased maternal age. Fetal growth disorders related to chronic maternal diseases or multifetal gestation. Fetal aneuploidy and pregnancies resulting from assisted reproductive technology have certain problems related to that. So the fetus may be affected by preterm delivery, whether indicated and conducted by the physician or the obstetrician, or it occurs on its own. Fetal growth restrictions and problems like that may occur. Fetal or problems may occur with multifetal gestations, fetal aneuploidies, and problems with assisted reproductive technology, ART. The morbidity to the fetus is increased with assisted reproductive technology. These are the problems associated with in vitro fertilization plus embryo transfer, or what we call assisted reproductive in general, before the IVF or after the IVF. So we know that about 40% of multiple pregnancies or multi-fetal pregnancies are due to assisted reproductive technology. And we know that multiple pregnancy has greater risks for both mother and the fetuses. Multiple pregnancy account for much of the morbidity and mortality from preterm delivery. This is what I have just mentioned. Assisted reproductive technology could be associated with placenta previa and placental abruption, because when we fertilize the ovum in the laboratory, then we have to transfer it back into the uterus. Implantation, we usually hope to be in the upper part of the fundus, but it could occur in the lower part of the uterus, and this could lead to placenta previa. Intracytoplasmic sperm injection, or ICSI, associated with significant increase with congenital anomalies than straightforward in vitro fertilization. That is the reference of this bit of information. So these are things or problems associated with assisted reproductive technology, and we have to give an advice for it before conception. We tell the lady what we are going to do. So what sort of counseling, knowing that these are the problems that may occur, so what sort of counseling are we going to give to the lady before conception? Low risks pregnancies, we have to address in all of them, but this is more in low risk settings. Balanced diet, That's to say, she has to have a normal body mass index, addressed to give them folic acid during pregnancy or before the pregnancy. If she had a history of neural tube defect, then we give her folic acid priorly in bigger doses. We have to advise her about the lifestyle. That's to say, reduce caffeine, alcohol, and she is a smoker, to stop smoking. All these affect the fetus. Review the past medical history. Review the family history, as we have mentioned earlier on, the siblings. We do genetic counseling. We review the obstetric history. We may take smear, and we check for rubella immunity. So these are issues which we have to address in the counseling. Having had an idea of what problems could occur, so this has to be addressed. So in a high-risk settings, beside what we have mentioned there, we look into medications. Are safe with pregnancy or change them? She is hypertensive, so this is a high-risk pregnancy. Hypertensive before the pregnancy. She is on treatment. Then we have to check the drugs she is taking and accordingly modify them or keep them. She is having thyroid problem. We have to do the same. So we have to have good control of medical disorders. That is in high-risk pregnancies. Usually it is always difficult for women to tell them that pregnancy is contraindicated in your case, because motherhood will usually be their choice or their utmost choice, even if they are having a disease that contraindicates pregnancy. So some diseases, we usually say pregnancy should not be undertaken, or she should not go for pregnancy. Pulmonary hypertension, some cancers, severe renal failure. These usually very high risk. If she had children priorly, you advise her not to get pregnant again if she had one of these problems. Yet she may not take your advice, and you be prepared to manage her as a high-risk pregnancy, as we will see in the antenatal care, the second part of the talk. So another thing we look into drugs. As we have said, if a lady had a medical disorder, she is already on medications, we have to look into that medication and see whether that medication is going to affect the fetus. Is it teratogenic or not? Accordingly, we modify the medications. Drugs which are teratogenic, warfarin. Given in the first trimester, it leads to warfarin embryopathy, which entails abnormal cartilage and bone formation. Given in the second trimester, leads to fetal cerebral hemorrhage. So if she is on warfarin, these are the possible teratogenic effects of the drug, and accordingly we have to modify the management for it. If she is having ACE and angiotensin converting enzymes, that leads to fetal renal dysgenesis, all trimesters. If she is having one of these drugs to treat her hypertension, we have to modify it. Anti-epileptic drugs lead to neural tube defects, oral cleft palates, and cardiac defects. Valproate leads to developmental delay in the second and third trimester. Tetracyclines lead to staining of the teeth given in the second or third trimester. Retinoids lead to multiple defects. So this is example of drugs. Teratogenic should be avoided during pregnancy. This is why preconceptionally you ask the lady about them and try and modify them. This is a good thing about the preconception counseling. Warfarin, ACE, anti-epileptics, valproate, tetracyclines, and retinoids. So having mentioned the preconception period, the lady now conceived and she is pregnant. After all your advice, after your knowledge about what to tell, what to stop, what to change, what to optimize, she is pregnant now. She is coming for the antenatal care. So what should we do in the antenatal care? The aim of antenatal care the aim of the antenatal care to optimize pregnancy outcomes for women and babies, to prevent, detect, and manage those factors that adversely affect the health of the mother and the baby. Prevent them. If they occur, you detect them early and manage them. To provide advice, reassurance, and education and support for the woman and her family. So here, family means both, husband and wife. To deal with minor ailments of pregnancy, headache, nausea, vomiting, you have to deal with that. And to provide general health screening for the lady. This is the reference from where we got this information. The perinatal death has been shown to be inversely proportional to the number of antenatal visits. That's to say, the more number of antenatal visits she had, the less likely that the perinatal death would occur. That's because problems will be detected and accordingly managed. Then in the antenatal care, we have to advise about whether the woman to deliver at home or in hospital. Obviously, high-risk pregnancies, all in hospital. Low-risk pregnancies, then you have the choice whether to advise her to deliver at home or to deliver in hospital, and in hospital to deliver in a general practitioner unit or a unit led by a consultant team. Because it has been shown that the gradual decline in maternal and perinatal mortality was thought to be due in greater part to hospital deliveries. The ultrasound introduction has affected greatly the outcomes. All pregnant women to be seen at least twice by a consultant obstetrician. These are the visits. So antenatally, at least a consultant obstetrician should see her twice during the pregnancy. The other times could be seen by other people or other part of the team. We know that new interventions have greatly reduced the perinatal mortality, morbidity, and also the outcomes to the mother. These new interventions are continuous fetal monitoring in labor and induction of labor. These led to reduction in perinatal mortality, but women led by groups such as the National Childbirth Trust began to question two things. One, is there a need for any intervention? What should you induce? Why should you induce? What should you monitor? These are women activist groups. The other is there a need to come to a hospital at all? They can tell you that our grandmothers have been delivering at home. If there's a good midwife at home, why should I come to hospital? So these are ideas or opinions which you will encounter in your practice. But it definitely has been shown that the fetal monitoring and induction of labor improve the perinatal outcome. Antenatally, we have to diagnose pregnancy initially. Symptoms: tiredness, lasts for 12 to 14 weeks. Nausea and vomiting, usually presents within 8 weeks of LMP. Hyperemesis gravidarum, that's excessive vomiting that leads to electrolyte imbalance and ketosis, is very rare nowadays. Symptoms of pregnancy: constipation in about 1/3 of the pregnancies. Heartburn also occurs with pregnancy. Hemorrhoids in about 1 in 10 in the last trimester. Varicose veins noted in some of them due to pressure. Change in nature of vaginal discharge may be due to infection by Trichomonas, Candida, or bacteria. So this is to diagnose pregnancy. Obviously, you take the history, and these are the symptoms which the lady could present with. And the signs, you see them: amenorrhea, symptoms and signs you have just mentioned. There are certain changes in the lower reproductive genital tract, and you will have that all during your obstetrical lectures. There are certain uterine changes in the size of the uterus, the weight of the uterus, the volume of the uterus. There are certain breast changes and skin changes. Fetal movement could be noted. Then you do pregnancy test. Having had the symptoms, the signs, you do the pregnancy test. These are either home pregnancy tests done by the lady at home, or quantitative measurement of beta HCG in the laboratory. All this confirming the pregnancy finally is by ultrasound or sonographic recognition. You do an ultrasound, and then you will see whether there is pregnancy or there isn't, even if she had the symptoms. So, beta human chorionic gonadotrophy, what is it? It is used for diagnosis of pregnancy, though sometimes, as we will see in a minute, you may find false positive. Beta HCG, the structure generally of human chorionic gonadotrophin, it is a heterodimer composed of 2 dissimilar subunits. These subunits are designated alpha and beta. The alpha unit or subunit identical to both LH, FSH, and TSH plus HCG. So the alpha unit will not discriminate, it could be either. But the beta subunit structurally distinct from that of luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone. So accordingly, we look for the beta subunit to diagnose pregnancy. Human chorionic gonadotrophin prevents involution of the corpus luteum, the principal site of progesterone formation during the first 6 to 8 weeks of pregnancy. That's to say, after ovulation, the ovum will be picked by the fimbrial end of the fallopian tube. It travels downwards by the cilia of the fallopian tubes. The sperm comes from the vagina, uterus, and also ascend up to the fallopian tube. They meet in the fallopian tube, and fertilization takes there. The fertilized ovum will come down and will be implanted on the uterus in an already prepared endometrium. That results in production of beta HCG or HCG in general, human chorionic gonadotrophin. That human chorionic gonadotrophin supports the corpus luteum resulting from the ovulation to maintain the pregnancy and produce progesterone for the pregnancy till the placenta takes over. In situ trophoblasts produce HCG in increasing amounts during the first trimester following implantation. Antibodies were developed with high specificity for HCG beta subunits. So antibodies developed, you can check on it. And this is what we do. The hormone can be detected in maternal serum or urine by 8 to 9 days after ovulation. That's to say, ovulation and fertilization. So after 8 to 9 days, fertilization has taken place, implantation has taken place, the hormone could be detected before the date of the next cycle. The doubling time of the serum beta HCG concentration is about 1 to 2 days normally. And we make use of that in certain diseases where the doubling may take longer than that or maybe quicker than that, depending on the production. Normally, in the normal pregnancy, the amount double within these 1 to 2 days. Home urine pregnancy test could be done. The blood pregnancy test, one employed technique is sandwich type immunoassay. This is what they do in the laboratory. So we check the pregnancy by the human chorionic gonadotrophin and we look for the beta subunit. This taken from a textbook tells you that the serum beta HCG levels increase from the day of implantation and reach peak levels at 60 to 70 days. Thereafter, the concentration declines slowly until a plateau is reached at approximately 16 weeks. So you can see here on the graph, it is increasing till about 70 days, 10 weeks here. Okay. Then it starts to decline at about week 16 or so. And then after that, it takes a plateau. Okay. A plateau is being taken at approximately 16 weeks. From here onwards, it is there. So the peak of beta HCG detected or human chorionic gonadotrophin is at about 6 to 70 days after implantation. That's to say it is higher than later on during pregnancy. As I have mentioned earlier on, we have, though it is very specific and the beta subunit is very specific, it wouldn't mix it up with the FSH, LH, or TSH, but there are certain situations where you may get a false positive beta HCG. Positive beta HCG, no pregnancy. Here, situations like circulating heterophilic antibodies produced by some women that bind erroneously, wrongly. Other rare causes of positive assays without pregnancies are exogenous HCG injection used for weight loss. That's to say the lady is being given injection medically of beta HCG, being used to, in some cases, to lose weight, or a renal failure with impaired HCG clearance. So she is not pregnant, but she had this situation that will give you a positive beta HCG. Physiological pituitary HCG and HCG producing tumors that most commonly originate from gastrointestinal tract sites, from the ovary, the bladder, or lung. If there are rare tumors, they could produce beta HCG. So in this situation, you tend to get a positive beta HCG without pregnancy, and you have to look for it. Exogenous being given to the lady, renal failure, physiological pituitary, and tumor producing HCG. That is the end of our first part, and then we'll go into the next part of it. So we stop here.